Welcome, everyone. Thank you for joining Continuous Learning with Biography. It is my pleasure to introduce today's webinar speaker, Dr. Wei-Yau Shia. Dr. Xia earned both his DBM and PhD degrees from the College of Veterinary Medicine at National Chung-Hsing University, Taiwan. He currently serves as an associate professor in the Department of Veterinary Medicine at National Chung-Hsing University and is also the Director of Surgical Medicine at the National Chung-Hsing University Veterinary Medical Teaching Hospital. His areas of expertise include small animal surgery and small animal bacteriology. In this lecture, Dr. Xia will address this ongoing challenge of surgical site infections, or SSI in short. Despite advances in preoperative preparation, antibiotics, prophylaxis, and surgical techniques, SSI continues to pose a significant clinical concern. The webinar will highlight recent progress in preventing SSI in small animals and emphasize the importance of appropriate antibiotic use in reducing morbidity, costs, and antimicrobial resistance. We are honored to have Dr. Xia with us today. Without further delay, please join me in welcoming Dr. Xia.
Thanks for the introduction. I share the slides. Please wait a minute. Okay. I want to make sure that everyone can see my slide here.
Yes.
Okay. Let's show the slide. Okay. Thank you for the introduction. Good night, every doctor and student. I'm Dr. Xia from National Chung-Hsing University in Taiwan. Thanks, BioGuard, for inviting me to have this webinar tonight. I'm glad to see you doctors are still willing to participate in this webinar after reading this title. I believe all you doctors are striving for better surgical outcomes, so you are here. My speech today will not directly increase your earning, but I hope it will provide you with a higher quality of surgery and increase the respect of the owners in the future. I think this surgical site infection is a very important issue for our veterinary surgeons. Today, I will introduce the basic concepts and definition about the surgical site infection. What are the risk factors of SSI and some evidence-approved measures for prevention of SSI. Next, I will talking about the prophylactic antibiotic use, including the necessity, how to selection, when should we use, and when should we stop. At last, I will prepare two cases discussion. Even today, some serious problems still occur under modern principles. These principles including the preoperative preparation, antibiotic prophylactic use, and refinement in operative techniques. We must know and realize that when surgical site infection occurs, will cause discomfort to affect animals and also will cause client dissatisfaction because of the animal suffering and mostly due to the increased cost. And this cost will owing to the prolonged hospitalization and the treatment. Let's see the studies from the SSI report. This retrospective study enrolled 769 tibial surgery during 2005 to 2015, performed in the Bern University in Switzerland. The tibial surgery is a kind of a clean orthopedic surgery used to stabilize the stifle joint after cranial cruciate ligament rupture. even though the surgery performed under well-trained doctors and procedures, the surgical site infection rate still have 8.5%. Another study is revealed the SSI rate in soft tissue surgery in dogs. In this 184 patients, the SSI rate in total is 8.7%. And this study will divided into different category of the to clean or dirty surgery. So in here we can see in clean surgery, the SSI rate is about 8%. However, for the dirty surgery, the SSI rate will almost be double to the clinical surgery. And when this kind of SSI occurred, the total cost will increase about 75%, and most of the increase will happen after the surgery, and the cost will increase about approximately 1.4 times. And what exactly is the SSI? The surgical site infection indicates that the microorganism introduced into the surgical wound at the time of the surgical procedures. And the source of this pathogen will come from the endogenous or exogenous. For the endogenous, the patient's normal flora in the oral cavity or intestine or even skin all have a microflora. This kind of endogenous pathogen is very commonly to seen and will compromise these aseptic procedures. And the exogenous will be the air in the operating room, surgical equipment, or the medicine administered during the surgery. The most commonly mentioned medicine will be the propofol during use in our anesthesia. Later, I will explain the reason why. And next, in this table, according to the US CDC, this is a criteria for defining the surgical site infection. And in this table, mostly will divide it into three main factors. The first one was the timing, location, and the clinical signs. And the different location will including the incisional surgical site, or in specific organ or space, such like abdominal or thoracic cavity. For the incisional surgical site, will subdivided into superficial and the deep. So at first, for the factor of time of the timing, if the surgery, we did not use any kind of implant during the surgery, all the surgical site infection may occur within 30 days. However, if we use any kind of an implant during our surgery, the surgical site infection may occur within 1 year. This timing highlights the importance of when we're doing the surgery to manipulate this kind of implant require very strict aseptic procedures to prevent any kind of bacteria attached to the implant. The next will be the location. The location will be superficial to skin or subcutaneous, and to deeper fascia, muscle layer, and even to the organ or the abdominal or thoracic cavity. The most commonly mentioned clinical sign, including the purulent drainage from superficial, deep, or even organs, and also the culture, positive culture, aseptically collected is very important, and also the pain, abscess, or fever. So what kind of the risk factors will cause this kind of surgical site infection occur? Here I list the risk factors from surgical, at least the risk factors they are commonly mentioned in the textbooks. Owing to the limit of time, I just quickly review all these factors. First one, we all can agree that the infection rate is positively correlated with the degree of contamination. In this table, they differentiate different kind of contamination level from clean to dirty. So for the clean surgery is defined to non-traumatic, non-inflamed operative routes. The infection rate will to 2 to about 5%. Clean contaminated refer to respiratory, gastrointestinal, and the genital urinary tracts. All these system or these area we do the surgery have a kind of many normal flora around here. So it's clean to contaminated. The infection rate will be 3.5% to 5%. Contaminated will refer to traumatic wound, but without the purulent discharge. And if we doing the surgery, some gastrointestinal content spillage around our aseptic area or to compromise the aseptic procedure, then this kind of surgery will refer to contaminated. The infection rate will up to 12%. For dirty surgery, it's referred to traumatic wound with the purulent discharge. And this kind of surgery, the infection rate will raise to 60.7% to 18%. So from this table, we can see that the dirty surgery is very much time, about 2 to 3 times more than the clean surgeries. And many other factors can still affect the infection rate. So from the previous study, we already know the tibial, the clean orthopedic surgery have a occurrence of the SSI is 8.5%. It's also higher in here is the clean surgery. So the many factors also involved in all the procedures. And the other another study also showed the clean orthopedic surgery had an infection rate as high as 15%. So we have to remember the factors is very complicated. So before we do the surgery, we must to define the contamination degree of our patient and try to decrease the contamination level before the surgery. This will be very important to prevent the infection SSI happen. The second is the surgical site preparation. Later, I will demonstrate some evidence-based procedures when doing surgical preparation. For the duration of surgery and the anesthesia, different studies indicated prolonged surgical or anesthesia time had increased SSI rate. Because this kind of a long duration will cause significant decrease of CD4 and CD8 lymphocyte. This will compromise our immunity. The anesthesia time mentioned here is independent of duration of surgery. Here is referred to pre-surgical preparation and some image examination, such like the CT scan or MRI scan. The propofol is very commonly used while we do the anesthesia. It is susceptible to bacterial contamination because of this lipid-based formulation will support the microbial growth. The more number of people in operating room will equal to more walking and talking during the procedure, and thus will increase the contamination. The endocrinoplastis, the most commonly mentioned disease will be hypothyroidism and the Cushing disease. All these disease will compromise the local or systemic immunity. The sex factor indicated the sex hormone such like androgen will immunomodulating effect and will result in intact male dog or cat more prone to infection. The other factors including perioperative hypertension, hypothermia, and malnutrition. I review all these commonly mentioned the factors related to the risk factor of SSI. And next, I made this table, this figure from a review paper published in 2015. All these factors will given us a big picture, the picture about the risk factor of the SSI. The first, we can see in here the degree of bacterial contamination, the surgical site preparation, propofol, and the number of people in operating room. All these factors are correlated with the microbial concentration and the virulence. And the next, the duration of the surgery, duration of anesthesia, endocrinopathies, and the sex. All these 4 factors are related to the general and the local immunity. So in this figure, we can see the 6 factors will related to increase the risk of SSI, the microbial concentration and the virulence, tissue injury, foreign material, antimicrobial resistance, general and local immunity, perioperative antimicrobials used during our surgery. So the textbook tells us the risk factors most correlated to this the only microbial concentration and virulence or the general and the local immunity. Another very important factor correlated to the microbial factor will be the antimicrobial resistance. Another factor I want to mention here is the virulence. The virulence related to the risk of SSI will be the biofilm formation of certain bacteria. This biofilm formation will cause the bacteria more easily to attach to the tissue and also to prevent the antibiotics to penetration into the bacteria and cause the increased antimicrobial resistance. So the antimicrobial resistance is also a very important factor to cause risk of SSI, such as the MRSP is the methicillin-resistant Staphylococcus pseudointermediates. This kind of bacteria have a very high resistant profile. So we commonly use the prophylactic antibiotic such as Cefazolin or Cefalexin. We cannot kill or inhibit this kind of bacteria, then the surgical site infection will occur. Then the next one will be the tissue injury. Tissue injury mentioned here is highlighted the compromised blood supply before and after the surgery. Because the blood supply for the tissue is very important to transport our leukocyte to the surrounding tissue and also the nutrition. Even we given any kind of antibiotics, we need a good blood circulation to bring this antibiotic to the surrounding tissue to kill the infection pathogen. So if the more tissue injury, the more compromised blood supply, then the infection rate will increase. The next will be the foreign material. Foreign material is the same as the tissue injury. This kind of material did not have any kind of blood circulation and the blood supply. So if the bacteria attach to this material, or even though, and also with any kind of implant we use in the fracture fixation, the bacteria attached to that, then no blood supply on this the implant and the foreign material, so will cause the persistent bacterial growth and infection. And the last, we can see The 4 factors, microbial concentration, the virulence, tissue injury, and the foreign material, and the antimicrobial resistance, all these 4 factors will increase the risk of SSI. If our patient have a good and normal general and the local immunity and the perioperative antimicrobial and the correct use of the perioperative antimicrobial use, then we will have a good effect to against this kind of risk of the surgical site infection occurred. And next, I will show the previous slide. We just mentioned the TPO surgery. The surgical site infection rate is 8.5%, and in these 65 patients have SSI occurred. The most frequently isolated pathogen will be Staphylococcus pseudointermedius and also the aureus. And more than 1/3 of the Staphylococcus pseudointermedius and about 50%, half of the Staphylococcus aureus, all classified as a multi-drug resistant strain. And this very high antibiotic resistance will cause our prophylactic antibiotic use failure. So the correct use of the prophylactic antibiotic is very important to prevent the further induction of bacteria to produce multi-drug resistance. Next, I will show here. This concept will be very important. And before we use any kind of antibiotics, we should be clearly differentiate our purpose is used for prophylactic or infection control. The key point is whether an infection was already presented at the time of the surgery. If no infection occurred before the surgery, then antibiotic use in here is for prophylactic. Next, I will show you the principles of the prophylactic antibiotic use. Antibiotic prophylaxis is the use of the antibiotic to protect our patient from bacterial invasion. Because we could not create a complete sterile environment or sterile wound. So when we do the surgery, the host will face to the decreased systemic or local immunity. So the wound will be very vulnerable to the infection. So if we use the prophylactic antibiotic, we should use under these 2 circumstances or situation. The first will be the risk of infection is relatively high. We just mentioned for the surgery, for the contamination degree in clean to contaminated or contaminated operation, this kind of a surgery will high infection rate, so we can use the prophylactic antibiotic. The next will be the development of a surgical site infection will have disastrous consequences, such like the hip joint displacement. This is a very important surgery, and a lot of implant use in the hip joint. If the surgical site infection occurred, is a kind of a tragedy and very hard to remove this kind of infection. So the prophylactic use is necessary. If we use the prophylactic antimicrobials, there are 3 elements we need to know. The first is how to select the correct antimicrobial agent. The next will when to give and when to stop use of these antibiotics. For the selection, the table show the surgery we encountered in different area, and this area have some kind of normal flora or some pathogens will cause the surgical site infection. So the effective against the organism expected to be encountered is very important for the clean procedures, such like I show our laser point. Okay. So for the clean surgery or clean procedures, the neurosurgery or the orthopedic surgery, these two kind of surgery, the most commonly will counted the pathogen will be the Staphylococcus. For the clean contaminated surgery, the area will be including the gastrointestinal or genital urinary, and also the oropharyngeal. This kind of location all have enterobacteria located here. So for the prophylactic antibiotic use, the cephalosporin, especially for the cefazolin, the first generation of the cephalosporin, is the first choice to use when we use for the prophylactic antibiotic. If we use the more advanced cephalosporins, such like the third generation or fourth generation, this kind of cephalosporin will have a better gram-negative activity, but we should remember the gram-positive activity will dramatically decrease. So if we use the antibiotics such as first generation cefazolin will have a very good effect to the Staphylococcus. If you use the third or fourth generation for control the Staphylococcus infection, the effect is very, very bad. For the prophylaxis, we need effective antimicrobial concentration to protect from bacterial invasion while making the skin incision. So when we do the surgery, we make the skin incision. We want the antimicrobial concentration to reach the MIC is a minimal concentration to inhibit the bacteria. So we want to give the antibiotics 1 year before the incision making to make sure the antibiotic also already given into the blood circulation and bring this antibiotic to the surgical site and have a good concentration. And during the surgery, we repeat dose for every 90 minutes or 2 hours. The additional dose for 1 or 2 following the surgery finish, we want to suppress the late growth of the contaminating organisms. So if you wondering some kind of a slow growing of the bacteria in your surgical site, maybe you can use additional 1 or 2 doses of antibiotics. And when should we stop? We always remember if our antibiotic is used for prophylactic, we should not be administered the antibiotic beyond 24 hours post-surgery. The prolonged post-operative antibiotics will change the antimicrobial susceptibility of our pathogen. It means they will cause the more resistant bacterial strain in your surgical site. And the study also shows us the higher infection rate in group used for therapeutic post-operative antibiotics. It means the longer time for the antibiotic use. This will cause the more infection rate compared to the only use the prophylactic in clean procedures. Okay, the next, we already know the principle and when and how and when to stop these antibiotics. So the surgical prophylaxis is clearly indicated in patients with only for high risk infection rate, because of the contamination category is high when we do the surgery. And also, if our surgery will expected to have a longer duration and a longer anesthesia time, this will cause the I just mentioned the immunity will kind of compromise, and the infection rate may increase. So we can use the antibiotic in this kind of a surgery. And when to use prophylactic antibiotics in low-risk patient, just like I just mentioned, is a hip joint displacement for when post-operative infection will seriously endanger the health and the outcome of the surgery. Then we have to use this antibiotic to prevent this happen. This is a table and figure from the Wasaba and show to the concept of the surgical antibiotic prophylaxis in dogs given to for further information you can see. And in here we're talking about the antibiotic use when the surgical site infection had already occurred. The previous I just mentioned for the prophylactic use of the antibiotics, and when the surgical site infection already occurred. So in here, the broad spectrum therapy is initiated, and the sample culture from the infection site to perform is very important. And the next, our therapy, our antibiotic use will according to antimicrobial sensitivity in 20 or 70 hours according to our laboratory to give out the results. Before we have received this antimicrobial sensitivity test result, we can do the grandstand first to make sure our specimen have a gram-positive or gram-negative the bacteria, and you can, according your experience, to give the correct antibiotics first. Our goal to definite therapy is to providing optimal chance for cure is by using the narrow spectrum. Why using the narrow spectrum? Because narrow spectrum antibiotics will not compromise our own normal flora for our gastrointestinal. The broad spectrum will cause more our biofilm, our normal flora to have a kind of unbalance, and also will increase the rate, the prevalence of the resistant bacterial strain, increase the occurrence. And the next we want to use the cost-effective, it's a cheaper antibiotics and a safer agent. This kind of criteria is sometimes it's very hard to reach in our real life, but we have to remember if we have an opportunity to this kind of antibiotic we can use is for a narrow spectrum and it's a cheap and safe. This will be the first choice. And the next, we always to remember to select the correct dose and the interval, because the different kind of antibiotic have a different bioavailability. So if you use for oral medication, if the gastrointestinal the resorption rate is very low, even the antibiotic for in vitro test is very sensitive, but in the real animal body, the effect is still very bad. And here I want to share some information about the BioGuard have already developed the mini AST, the machine. In my opinion, I want to share some information to all your doctors. Before we using any kind of automatic AST machine, is an antimicrobial susceptibility test machine. We have to know our specimen and our infection agent is what kind of characteristics. The first one, before you do this AST, you have to do the aseptic sampling. If you sample your infection site with a contamination, then the AST machine will only give you the contaminated bacteria result, not your pathogen to cause the infection. The second, the grandstand is very important. It will tell you your specimen in your infection is only by a single or complex pathogen. If the complex pathogen exists in your specimen, they will be fast growing or slow growing. If you just give the complex pathogen to the automatic AST machine, then maybe you only will receive a fast growing bacteria result, but not the lower. So the mini AST, I think, will be better suitable to only a single bacterial pathogen induced infection specimen. I want to share this information. And I will show some antibiotic characteristics in here. The antimicrobiotics have two different kind of category. One is the concentration-dependent antibiotic. The other one will be the time-dependent antibiotics. The concentration-dependent antibiotics in here, they have two keywords in here is the C maxima and the MIC. The C maxima means the peak is the highest concentration of our drug given in the animal IV or given oral medicine. So when the maxima of the concentration reach, will call the C max. The MIC will be the minimal inhibitory concentration. Is the minimum concentration to inhibit the bacterial growth. So for the antibiotics is belong to the concentration-dependent antibiotics. The higher C maxima to minimal to MIC, C maxima to MIC concentration, the ratio higher then will given to a better response. What kind of antibiotics is belong to here will be fluoroquinolone, metronidazole, amphotericin, and the aminoglycoside. So in these four different category of antibiotics, the fluoroquinolone, such like Bactriol, enrofloxacin, this kind of antibiotics will commonly used in our small animals. So when we use the Bactriol or enrofloxacin for control the infection, we prefer to use single high dose to reach a good C maxima and to the MIC ratio, then we'll give a better response, but not use divided dose to reach a lower C maxima. The effect will be not good enough. And the other one will be the time-dependent antibiotics. The time-dependent antibiotics means we want to let our drug, the concentration above the MIC, the time longer is better. So equal or greater than 50% of the dosing interval. So you can see the figure in here. If we give our antibiotics for 8-hour interval, then when we repeat the dose, most of the time, the antibiotic concentration all above the red line. Red line is the MIC concentration. So the time longer, the effect will be better. So the efficacy correlated with the time greater than the minimal inhibitory concentration. Beta-lactam, clindamycin, macrolides, azole and vancomycin all belong to time-dependent antibiotics. So when we use the cefazolin, cefalexin, amoxicillin, augmentin, all belong to the beta-lactam antibiotics. So when we use this kind of antibiotics, we have to more frequent use for at least BID or maybe TID will have a better maintenance effect to inhibit the bacterial growth. Okay, in this slide, I will show some pictures to demonstrate some evidence-based we accept the measures for preventing the SSI. There will be 5 procedures showing here. The first one will be the preoperative preparation for the hair clipping and the surgical site disinfection, prophylactic antibiotic use I just mentioned, and how to draping and the incise film use, and the double gloving, and when to change. The first one we can show in the right is a picture. When we do the hair clipping, if the patient is still is not under anesthesia, then when you do this kind of a hair clipping, will very easy to have a skin damage to compromise your skin, the integrity. Then if when you do the hair clipping cause the skin damage, that will increase the SSI rate during the surgery. And the surgical site disinfection. Okay, so we prefer to clip your patient the hair under the anesthesia to make more stable situation, and do all this procedure outside the surgery room, not inside. Because this the hair in the air and also in the ground all will make a very severe contamination to your environment, and try to best to avoid the skin damage when you hair clipping. And also in this picture, you can see the limb have a lot of the small papules in here. So the dog may have some kind of a superficial pyoderma. The patient will ready for the MPL surgery. It's a medial patellization surgery, and also we will going to the stifle joint to do some to stabilize the patella. So if this kind of a skin infection already occurred in the animal, you have to have a very be careful when you do the pre-surgical preparation, including the good hair clipping and also the disinfection, the procedures. The next I will show you how to prevent. So the next will be the surgical site disinfection agent use, the chlorhexidine or povidone iodine, or you can use. But remember, if you use the povidone iodine, this kind of agent will need a longer time to contact to the skin, will have a better inhibitory result. And use the enough repeat and the range. The range should not too small. Then you have to, for example, in this case, we only manipulate the stifle joint in here, but we remove all the limb, the area, the hair removed to prevent some kind of a contamination during our surgery. And the prophylactic antibiotic I just mentioned, we have to evaluate the contamination rate or contamination degree in your patient. And if you want to use, then you give the antibiotic 1 hour before incision and then boost every 90 minutes. When we draping the surgical wound, here I demonstrate I use the incise film attached on the skin. This incise film is a very good prevention procedure when you do more deeper and also some orthopedic surgery. This kind of incise film have iodophore impregment, and so this iodine will continuously release to from the film to prevent the contaminated bacterial growth. But if you do not well stabilize this incise film, such like in here, I will use the simple continuous suture to stabilize this film. Very good to attach to the skin. If you do not use this kind of procedure, then this incise film will very easily to removed or dislocation from the skin. And this kind of a situation happen. Some studies show this will cause even higher surgical site infection rate compared not used to use. And the next will be the double growing or the constant change our growth. The double growing is a very good prevention procedure too. When we manipulate some implant, iron pin, or screw have a very sharp and maybe compromise or cut our growth to make the contamination occur. So before we manipulate any kind of implant, we just mention this kind of implant without any blood supply on that. So when we approach our soft tissue into deep area, and when we touch the implant, our growth, if I have any kind of bacteria on the growth to attach our implant, then this kind of infection will occur after our surgery. So before manipulate our implant, we recommend to change our outer growth to a new one. Then we manipulate our implant. And the second, before we suture close our wound, then change to a new one, a new outer growth to make this suture will be better to prevent for long duration of the surgery. Our growth have already touched the blood or some fluid. They will air dry, and the bacteria may attach to your growth. All these kind of factor may cause the surgical site infection. So before closing, wound closing, you can change the outer growth to a new one. Okay, I will show two cases in here. The first case will be a 12-year-old female spayed, the mixed breed dog, weight is 34 kilograms. This dog have a left tibia and fibula fracture with open wound for 6 days. And from the open wound, we already see the purulent discharge observed. And before we do the surgery, the preoperative antibiotic augmentin have already used. So from this introduction, we already know in this case, it's a traumatic injury, have an open wound, and is with purulent discharge. So the contamination degree will almost to the 30. So I want to ask all you doctors, please give me the response to the Q&A, the box. For the decision making, the first one, you just use the empirical antibiotic treatment first, then do the orthopedic surgery. And then the antibiotic AST performed when infection control fail is the operation decision one. The option two will you first use the empirical antibiotic treatment, and then you sampling the purulent discharge for ST. You get the result, then going to the orthopedic surgery. At last, the post-operative antibiotic according to ST result. So if you may, please give me the answer for your choice, the option 1 or option 2. 1, you just do the given the antibiotic first, and do the surgery, and then according to the ST result to only for the infection control fail, then you do the ST. The second will be given antibiotic first, then sampling, and then do the surgery and use antibiotic according to the AST. I think I can see your answer in here. I'm not sure can see the
Yes，夏老师，你可以看问语答 Q&A 那边。
Q&A. Okay. Okay, so most of doctors will choose the option 2. Thank you very much. So next, I will show how I deal with this case. So in this case, the preoperative antibiotic used, the augmentin used, I just mentioned. And then we do the surgical debridement surgery and tissue sampling and fracture fixation last. So at first, I do the surgical debridement surgery is one to remove the devitalized tissue, the infection and the pathogen from the skin. And we want to have a good blood supply around this surrounding tissue, because it's a kind of a chronic traumatic wound with infection. This kind of granulation formulation around this chronic wound will compromise the blood supply. So I first do this debridement surgery. And the tissue sampling, very important here, we do including the superficial and also the deep area. The deep area is the tissue around the fracture line, the fracture gap, the fracture area, and also the granulation tissue. All this procedure already finished. We use a lot of saline to lavage this fracture gap area and the infection area. Then at last, we do the fracture fixation. So in here, this picture, you can see the incise film attached. I still use the simple continuous suture to stabilize this incise film. And also in this granulation tissue, I try to make the tissue fresh and remove a lot of the as much as we can to remove these pathogens from the fracture line. And when we do the fracture fixation, we make a new incision, but not the same area from this open infected wound, to prevent the pathogen migrate to the bone area. In here, I showed the antibiotic resistant result. One is the specimen from the superficial wound. The second will be the deep granulation tissue. So you can see these two results is different. From the superficial wound, only culture have only E. coli and only 1+. But from the deep granulation tissue, they were including 2 different bacteria. One is the E. coli. The second is the Enterococcus faecium. This is a highlight the importance of our specimen sampling. We have to sample as deep as we can. because if you only sample from the superficial or only from the purulent discharge, then your result may only have a E. coli result. Deeper area, we can see the true pathogen to cause this animal infection. So from the result, you can see the E. coli have some antibiotic have susceptible to intermediate for ciprofloxacin, enrofloxacin will be intermediate, but for the enterococcus, almost antibiotics all resistant. Only vancomycin and lisolid is susceptible. So according to this result, in this case, we combination two different kind of antibiotics is enrofloxacin and lisolid for the final treatment. So after about we do the surgery in January and have the last X-ray, the examination performed in May for about 3 months is the duration. You can see from this fracture gap, the bone eventually have callus formation. Even though the fracture line still can observe, but the callus formation have already seen from the radiograph. So, and if also we cannot see any active infection around the screw. So the infection control is accomplished. And the second case is a 9-year-old castrated male, British short hair and exotic short hair mixed cat. This cat have already done a perineal urostomy surgery 2 years ago. After that surgery, the cat still have a chronic hematuria with polyuria after previous surgery. And the regional animal hospital had already diagnosed the cat had a Cystolithiasis. And so you can see the X-ray, the urinary bladder have a lot of stone in here. So again, I want to ask you all doctors your decision making. The option 1, for this cat, you just do the surgery to remove the stone and give the empirical antibiotics. The option 2, you give the empirical antibiotic first and do the surgery later. The third option is you do the urine analysis first and then do the surgery, and you use the antibiotics according to the sample from the urine analysis. So please give your answer if you can. Okay, so 2 doctors, option 3. Okay, I very welcome to if you can interact with me. Okay, so I show you how I deal with these cases. So for this case, we do the preoperative urine culture first, because according to the history, the cat had already a very chronic hematuria and polyuria for a long time. So it's very easy to recognize this cat have a very high possibility to give a long-term oral antibiotics for a long time. So in this kind of a bladder stone, the cystolithiasis, the infection in the urinary tract is very highly possibility, and also the pathogen may also have a very high antibiotic resistance. So I want to make sure the urine is have any kind of pathogen here, and also want to make sure the antibiotic susceptibility, the resistance. So in here, follow the figure. In this cat, later I will show the result. the microbial concentration in the urine is high, and also the bacteria, the antimicrobial resistance is also very high. The bloodstone is a kind of a foreign material. All these factors will cause the very high risk of SSI, even though so I want to use the perioperative antimicrobials to let the animal, the contamination risk to getting lower to prevent this infection occur. This is the AST result. You can see in the urine culture of Staphylococcus pseudointermediates, and also we can see a lot of most of the antibiotics is resistant. So cefazolin, I think in here have cefazolin, no, only cefazolin. Okay, according to this result, this Staphylococcus pseudointermediates is a multi-resistant, methicillin-resistant Staphylococcus pseudointermediates. So if we just direct do the surgery and we only use the prophylactic antibiotic cefazolin, then the infection cannot be controlled. And also, if you doing the surgery, the urine spillage outside your surgical field, then going to the abdominal cavity, that will cause the peritonitis. It's a very severe complication after the surgery. So before this surgery, I do the urine culture first to make sure what kind of antibiotic is effective. So before surgery, I use the Lysolic for this cat for 2 weeks to control the urinary tract infection first to lower the contamination rate, the degree. And the next, I do the cystotomy and the intraoperative sampling again during the surgery. And we given the post-operative antibiotics. When do the sampling from during the cystotomy surgery, we will sample the urine and the bladder mucosa at the same time. We have to remember the most of the bacteria will attach to the mucosa. So if we only take the urine for ST, the result will be a short negative result. But if you take the sample from the bladder mucosa, then the true result is they will give the true result. And also the negative growth will also come from the animal still using any kind of antibiotics. So antibiotics in the urine will also have some inhibitory effect of your urine sample. So gram stain still is very, very important to make sure the bacteria exists or not. So in this cat, we do the surgery, and after the surgery, we continuously give the Lysolic antibiotics for another 2 weeks to make sure all bacteria already killed inside the bladder. Okay, at last, the speech today. I want to remember something. All these things. The refinement surgical techniques is very, very important. We have to follow the Hostin principles. These principles tell us to prevent more tissue damage and keep the blood supply and have a good aseptic surgical procedures, and don't only rely on antibiotics for preventing SSI. Use antibiotic wisely and precisely, and repeat the respect. Always to respect our surgical asepsis procedures. All these factors we have to be remembered, and something we can control is from the decreased microbial concentration, decrease the tissue injury, remove any kind of the foreign material. And antimicrobial resistance we cannot control, but we try to prevent is come from the correct use of antibiotics. Immunity, we try to stabilize, but we cannot control very well. Perioperative antimicrobial use correctly, precisely. And last, we have to remember the proper surgical asepsis require teamwork, just like a symphony. Not only should we doctor follow, but also include our technicians. Only when all members are aware of the importance of aseptic techniques, all the previous simple but easily ignored procedures could be carried out consistently and effectively. May you all have excellent surgical outcomes. Thank you for your listening. Okay, here is my presentation here. So if anyone have a question, please give the message in the Q&A and make sure I can see the questions. So the Dr. Low, can you hear me?
Yes.
Okay. So here is for Q&A, right?
Yes.
And make sure what the question. So Senjoy, please send me a PDF. Okay, PDF, I think the BioGuard company will give you a slide after this webinar. It is advised to keep the different prophylactic and EPS what to give a different prophylactic and the different post-op antibiotic. If yes, what two antibiotics would you recommend it? Okay, so for the question here is asking about the give a different prophylactic antibiotic and the different post-op antibiotics. In this situation, the same, we have to make sure what kind of surgery we encountered and also what kind of bacteria may cause our surgical site infection. The different kind of a category of antibiotic use at the same time. We try to avoid this situation because even though we use the Cefazolin I just mentioned for prophylactic, the first choice. After the surgery, you use maybe bacterial or any other kind of antibiotics. The different category of the antibiotics have a different mechanism of the inhibition. So we try to only use the same. Maybe you just use the beta-lactam for cefazolin. You can change to cefalexin for oral, or you can use if you a fear of the infection will be more complex. Maybe the augmenting is another choice. So we just not to try to prevent to use a different category of the antibiotic at the same patient for the same time. And if you want to change the different, always according to the AST result will be better. And okay, any question? Can I have a PDF? Okay, I will show you later after this webinar, the company will give you a copy PDF. A lot of doctors want to PDF, so please, the Dr. Low, give the doctors the slide. Taking sample from the urine bladder mucosa, I've been taking biopsy during cystotomy. Is that unnecessary? Is a swab or mucosa enough? If you can, I still recommend to use the cutters, a piece of urinary bladder, the mucosa, to do the ST examination will be better because the swab from the mucosa, this kind of bacteria may attach to the mucosa is very tightly. So even though you use the swab for sampling, the number of the bacteria contact on the swab is kind of lower. And also, I just mentioned this kind of animal mostly still under antibiotic treatment. So all these factors will cause the bacteria growth decrease. So we try to give the laboratory have a good sample and enough the concentration, the volume of the bacteria to let the growth success to give the final result better. So I would still recommend to do the taking biopsy, or after you do the cystotomy, you just cut at the edge of your incision site a piece of a mucosa to the lab to do this the ST. Another question. Okay, so is any question I did not answer in here? Please tell me, I can help you. Okay, this question is Yang Zhongwu. What kind of a sample should we sample for culture? In case 2, you sample the mucosa. Is there any reference? Okay. I think a lot of paper already mentioned about the urinary tract infection. Only the urine culture sometimes will have only show negative result. The bladder mucosa, according to the previous slide, I show you the virulence, the biofilm, and some bacteria have a good, very good biofilm formation ability. So this bacteria have produced a biofilm will attach to the mucosa or attach to any kind of tissue firmly. So if you only sample from the urine, any kind of antibiotic by IV or by oral medicine going to the blood supply, going to the urine. So the urine may have a good concentration, but the mucosa, if ulceration or any kind of damage, the bacteria will go into the deeper area, but not let the bacteria directly contact to the urine. So even though the urine have a good concentration of the antibiotics, still could not kill the bacteria inside the mucosa. So you incise a piece of mucosa will be better for a good ST result. So any kind of question I did not answer. Do you advise give a long-acting antibiotics as a post-op antibiotics? Okay, convenient. The long-acting antibiotics, I think it will depends on the situation. Still refer to the purpose from the beginning. The purpose of our antibiotics is used for prophylactic or used for the infection control. If you want to prevent the infection used for the prophylactic, you use the long-acting antibiotics. This kind of antibiotics used for, I think is used for infection control. So if this is a kind of long-acting antibiotics, well, eventually have some possibility to selection the bacteria to have a more resistant bacteria in your patient. So if you just want to prophylactic, you don't only use the short duration or only use the such like a Cefazolin only during your operation and only give 1 or 2 doses after the surgery. After that, beyond 24 hours, you have to stop any kind of antibiotic use. Only for the patient, maybe you do the fracture fixation or tibial surgery. We have a lot of studies show that after tibial surgery, the infection rate is still high. So we want to prevent this kind of situation. We will give another maybe 3 days or 5 days, or most surgeon longest duration or lower than 1 week, the post-operative antibiotic use for this kind of patient. So the long-acting, I think is not appropriate for prophylactic. Which type of procedure currently have the highest SSI rate? And what factor contribute most strongly? Procedure have a highest SSI rate, and what factor contribute the most strongly? I think again, this is a multifactorial. So from my slide here, again, make sure. Okay. So the most important factor, I cannot give you the very precise answer because always this kind of SSI happen is case by case. So if your case have a very severe the traumatic injury, so before the surgery, they may have a very severe car accident in the limb and have already open fracture occurred. And this situation, you did not do any kind of debridement surgery or disinfection of the surgical the open wound, then the microbial concentration will increase, and also the patient have a very severe tissue injury. The blood supply compromised very severe, and if the open wound have some dirt or some any kind of material inside the open wound, the foreign material may be inside your wound. All these factors will have a very high risk to cause the SSI. So I think the main factor is always case by case. I cannot give you the specific answer. Okay, then the next. What type of do you okay, I think I already finished all your questions. Okay, here I can see the new question here. Good evening, doctor. I don't really get your meaning and of giving second antibiotic dose within 90 minutes after the first antibiotic dose. Do you mean you use the same antibiotic for 2 doses, or they are different antibiotics to have the synergy effect? Okay, thank you for your question. So I mean, when we use the prophylactic antibiotics such as the Cefazolin, so before I do the skin incision, 1 hour before, I give 1 dose Cefazolin, maybe 20 milligram per kilogram. And next, during the surgery, for every 90 minutes, I give another 1 dose of Cefazolin. The dosage is the same. So this effect is Cefazolin is a kind of a beta-lactam antibiotics. So the frequent given will have a very good maintenance concentration above the MIC. to kill any kind of a bacteria may invasive to our surgical site. So I use the same antibiotic, not different, and the same dose. Just give say another time is before skin incision 1 hour before, and during the surgery for every 90 minutes I boost again. And also, how long will you suggest we use the post-operative antibiotics after orthopedic surgery? We usually use for 7 to 14 days. In what situation you will suggest longer period? Okay. Orthopedic surgery, if your fracture, the case is simple, without any open wound after the fracture, is a closed orthopedic closed fracture in your case, and blood supply mostly is not compromised very severe. I think the post-operative antibiotic you can use only maybe 3 days or 5 days will be enough. 7 to 14 days, a little bit longer, I think, but always depend on the case. So in what situation for the longer period? Again, we found the slide. And make sure. So you doctors can still see my slide? And make sure.
No.
No? Okay. I share again. Here. Okay. So for what situation, I will give a longer period of time. If this patient have a very bad immunity, and if the case have a very severe tissue injury, and also if the patient, you do the surgery for such a very long time, and also the aseptic procedure you do not very well. And even though the aseptic procedure you perform, but some kind of people maybe manipulate the implant such as falling to the ground, and you just take and did not wash very well, or do not any kind of disinfection, you just put it on the bone. All this kind of situation occurred will cause the SSI happen. So again, I want to highlight, always respect the aseptic procedures. And for the case we can control, we just want to minimize the tissue injury during our surgery, and remove any kind of foreign material, and try to lower the microbial concentration. So if for the longer period of time, I just answer in case have a more severe tissue injury or more longer duration in your surgery or anesthesia time. And if you can do the sampling before you finish your before you make the wound closure. Before closure, you can do a sampling from the incision site to make sure the contamination is not occurred in your surgery. If this the ST result show the no bacterial growth in your patient, then you can safely, you can comfortably to stop your antibiotic use, not have to given a longer time. In one of 4 cesarean C-section procedure, the uterine home body was difficult to get, so the vet had to incise while the uterine body was still inside the abdomen, causing some of the fluid to contaminate the nearby organ. would it be all right to pour an injective antibiotic-directed site? Okay. Some doctors may prefer to use this kind of injectable antibiotics direct on the site. For me, I would not recommend to do this because we have to know any kind of the spillage of the fluid have a lot of high concentration of the bacteria. They will diffuse into the abdominal cavity for a larger area. So only give a local and injectable antibiotic to a local area. The concentration, the above the MIC may be just around you given the area, but the surrounding, the bigger area, you cannot have a very good protection. So the most important thing is to use a lot of saline to lavish the abdominal cavity and try to aspirate all the fluid outside the abdominal cavity to remove any kind of contaminated bacteria inside the abdomen. I think it's a very better procedure to dealing with the kind of problem. Okay, I think I already finished all the question I can see. If you have another more question you want to know, you can just email to the BioGuard company. Then the company they will contact with me. I will try to answer your question. So I think that my webinar is finished in here.
Thank you, Dr. Xia, for delivering the outstanding lecture. We also extend our gratitude to everyone who joined us today. We look forward to seeing you in our next webinar. Thank you and good night.
Thank you, every doctor. Good night.